All right, ladies and gentlemen, we are back with another article, LLSA 2018. This one is called Imaging Foreign Bodies Ingested, Aspirated, and Inserted. We happen to have an expert here. His name is Jerry Gandalf Garcia. He can wield the double airways. How you doing today, Gandalf?
I'm quite well.
Oh, good. I'm glad to hear that.
For you two young fellas, you can use all of your sorts of fancy gamma radiation and picture taking. I will use my divining laryngoscopes, sometimes called laryngoscopes, depending on what school of wizardry you subscribe to find any foreign body.
So foreign body imaging, this is a really interesting article. There's a lot of things that we're really comfortable and familiar with, I think, with regard to foreign body identification removal. But there's some really cool pearls here that are dropped. For instance, like the radiographic visibility of foreign bodies. It's just because you have a foreign body that's radiopaque, it doesn't mean that you'll see it in every situation. It depends on different factors like the body habitus, anatomic location, the opacity of the object itself, certainly, but that's also relative to the surrounding structures. Like if a coin is in the airway, you'll clearly see it, but if it's surrounded by a lot of other similar type densities, then it may not be as easily visible.
I try to eat only one metal object a day to make sure that nobody's confused. That's my...
So this is something that we know a lot of when you do x-rays. Organic material like wood or plastic tends to be radiolucent. Stone, glass, metal is radiopaque. There are sometimes...
except aluminium, you may not see.
Aluminium, yeah. Very thin aluminum.
Remember when that was discovered? Aluminium. Cannot see it so well on X-ray.
I need the microphone volume, please.
Yeah. But there are instances that you should be aware of and to remind ourselves of when we should call emergency consults for removal, like button batteries in the esophagus. We all know that. Sharp formed bodies also in the esophagus. Those are all considered dangerous things that need to be emergently removed. Magnets, plural, or magnet metal pairs are things that are concerning. If they're within reach endoscopically, they should be removed. Obviously, if the patient's symptomatic with complete obstruction or perforation, yeah, you should be calling somebody for help. When it comes to children, the most common foreign body ingested is going to be coins in about 70% of the cases. And there's an interesting caveat to that because when you do the imaging, you might see a circular radiopaque object here, as you can see on the right, and on the left. However, we have to distinguish that from button batteries. And you can see what's called the halo sign because on the left, there's missing metal from the anodes, the positive and negative anodes. In the button batteries. And so that's one way to identify a potential button battery because your management completely changes. Coins oftentimes can just be monitored versus button battery. If they're asymptomatic, well, they need to be coming out because it can lead to like liquefaction necrosis or other sequelae.
It is the rune of Wonder Bread. I've not seen it in years.
Yeah, and so this is a very interesting pearl that was dropped in this paper. Plastic bread clips, they're notoriously difficult to identify on X-ray and even CT, and they've been associated, because of the way they're designed, they've been linked with
children,
increased complications such as perforation, obstruction, hemorrhage, for sure.
A known killer from time immemorial.
A known killer.
So be aware of those plastic bread clips. It's very contingent on the history. Hopefully they'd be witnessed. And so you just need to ask for it, get a good history. About oral contrast, this comes up every once in a while, whether or not maybe you should get the imaging with oral contrast to see if you can identify the object, but really don't.
Thank you for telling me that.
There are societies that are out there, for endoscopy that say,
you don't need
don't
the
do
milk
contrast.
thistle to find this.
Increases risk of aspiration, messes up endoscopy in the future, so just don't.
Drink it not.
Yeah. As far as ultrasound goes, unlike X-ray, there are some additional findings that you can see on X-ray. Ultrasound is very useful for superficial foreign bodies. Wood and plastic, while they might be radiolucent on X-ray, wood is hyperechoic on ultrasound, tends to be hyperechoic compared to plastic, as well as stone, glass, and metal are hyperechoic as well. But there are some interesting, unique visual findings where wood and stone have posterior shadowing versus glass and metal, which tend to have ring-down artifact. And so under linear high-frequency probe, you can see obviously the foreign body and the arrows pointing at the posterior shadowing. It looks like shadows. posterior to the foreign body, as opposed to ring down artifact, which is more reverberation. It's almost like ladder-like, posterior to the foreign body. So that's the distinction visually. When we talk about aspirated foreign bodies, it's mostly a bimodal peak with regard to distribution. Vast majority tend to be in really young children, 1 to 2 years. And then the older population, because they have some altered level of consciousness or a swallowing mechanism is impaired. For children, especially the aspirated foreign bodies, you want to get the 2-view chest and neck x-rays. You can also consider getting expiratory chest x-ray if they're compliant and can follow commands and direction. The lateral D-cube x-ray has kind of fallen out of favor because there's been conflicting evidence with regard to its actual performance. CT bronchoscopy is a modality you can also use, or you can just go straight to bronchoscopy as well. When you are getting end expiratory chest x-ray, what you're looking for is the hyperinflated lung. You can see here on the right patient's right lung, it's hyperinflated at end expiratory phase. There's concern about that ball valve mechanism where air gets trapped because of the foreign body that's not readily identified radiographically. Finally, talking about rectal foreign bodies, the rule is image first. I mean, however much you want to believe the person of what they inserted, here's a case where you have a crack pipe that was inserted, and you certainly don't want to be doing a digital rectal exam, especially if it's
that person's simply transporting that crack pipe.
Yeah.
It's not the actual foreign body.
And so there are also predictors that can tell you if your transanal extraction is not going to be very successful.
Transanal extraction.
That's
That was
right.
really politically correct. I enjoyed that.
Yeah, and so if the object is really long, greater than 10 centimeters, if it's been there for a long time, more than 2 days, if it's no longer in the rectum and the sigmoid colon, that's a problem, or if it's hard and sharp, all makes sense, common sense. So in summary, remember, identify the button battery. If you can see the halo sign and it's in the esophagus, the foreign body's in the esophagus, that's an emergency. You need to get endoscopy to remove it. Use ultrasound, especially for superficial foreign bodies. Plastic break clips are notoriously difficult to identify radiographically, and they can be dangerous as far as the complications go. And image rectal foreign bodies before the DRE.
Oh, click it before you stick it. So to speak.
Gandalf, yes.
I
That's enough for that one.
bless you by the laryngoscope.